Good morning, everyone. This is Essence.
Hi, Essence. Good morning.
Morning. We're going to be getting started pretty soon. Our agenda has been switched around a little bit. Previously, we usually do the updates in the beginning, but our guests from CHLA, they were placed in another meeting, so we're going to go ahead and put them in the beginning of the agenda and have our pediatric update first. So, Marjorie, I'm going to stop sharing the instructions and then I'll allow you to start queuing up your presentations.
Next week, Friday.
And just a reminder, so, we're still in this virtual world, so virtual world etiquette. If you're going to be taking any other calls or if you have anyone in your office or if you're not talking, if you can go ahead and place yourself on mute so that, all of those things, and it happens. So just be mindful of that. If you're not speaking, just make it a habit of keeping yourself on mute.
All right, good morning, Essence. Good morning, everyone. So speaking is Marjorie Smallwood. I'm the new emergency manager at CHLA. I'm actually going to turn it over to our director of emergency management, infection prevention, and accreditation and licensing, Marissa Glukoft. She's an epidemiologist by training and is going to kick off our pediatric presentations with an update on COVID-19 and school reopenings.
Good morning. Can I get permission to share my screen?
Yes,
Unless you'd like to share the slides.
I think you can. Are you able to do that now?
It says host disabled participant screen sharing.
Okay. Okay, could you go ahead and send it to me just in case what I'm doing right now doesn't work or takes too long?
Sure, yeah. Okay, I just emailed it to you.
Okay. Okay, I'm still waiting to receive it. Hopefully it comes in soon. I apologize for the delay. I thought I enabled screen sharing, so that's weird.
No problem. Your email address is eswilson@dhs.lacounty.gov.
Yes.
Okay, yeah, you did send it.
It could just be a delay,
Sure.
another delay.
Hi, Marissa. Hi, Essence. I don't know if we want to try sending internally, if it might be a little bit faster. Marissa, if you send me the slide deck, it looks like I have sharing access.
Oh, okay. It's the same deck, Marjorie.
It's the same deck? Okay.
Yeah, I can just forward it to you.
Okay, I think I've got it. Let me see if I can, oh. Apologies. So it looks like I have a icon that says I can share my screen, but it says host disabled participant screen sharing.
Ah, okay.
So while that's getting loaded, I just wanted to say good morning to everyone and thank you for the opportunity for our presentations today. Our topics are twofold. So the first one, once loaded, is COVID-19 and school reopenings, once again by our Director of Emergency Management, Infection Prevention, and Licensing and Accreditation for CHLA, Marissa Glukopt. She's also an epidemiologist by training and will give a great update there. The second presentation I'll provide, which gives a snapshot of COVID-19, the mental health effects of the COVID-19 pandemic on children, and what we're starting to see from a behavioral health perspective with our hospital and our census and some of our efforts that are underway. The second request was from one of our previous HPP calls during the spring. Some of our hospitals had a discussion around the uptick in behavioral health patients that we're seeing. And so there was a comment by the county and a recommendation to provide an update with regards to what we're also seeing for pediatric patients. So we'll share those two updates once able. And just wanted to thank everyone again for the opportunity to present today. I'll turn it over to Marissa. Looks like we're up. Thanks, Essence.
All right, wonderful. Thank you for that introduction, Marjorie. Next slide, please. Next slide. All right, so starting off with just some basic understanding of the scope of pediatric COVID-19. As you can see in this graph from the American Academy of Pediatrics, at the beginning of the pandemic, children represented a very small proportion of all cases. So this graph was began being produced on April 23rd. Children were 2.6% of all cases at the time. You can see that did start to change around November, December, January. Children became reflected a higher proportion of all cases. And in July, children are now 22% of all cases. Next slide. Luckily, children tend to have milder impacts from COVID-19, as you can see in this graph. Now, this hasn't been updated since February, unfortunately, but it still does remain accurate. And really what this is showing is that COVID hospitalizations are almost perfectly indirectly associated or inversely associated with age. So the highest rates of hospitalizations are in folks aged 65 and up, and so on and so forth. Children, you can barely see the lines that represent children on this graph because they're so close to zero. The gold and gray lines represent children under 18. So very, very mild presentations typically, not common to see hospitalizations. Next slide. Although, it looks like COVID didn't really impact children at the beginning of the pandemic, there's been some data to suggest that there might be some significant undercounting that occurred. And here's one study from Mississippi that looked at data from May to September of last year. And during that time, the state had reported about 9,000 cases. But researchers decided to do random antibody testing of blood specimens that had been collected just to see if maybe there had been some undercounting. And based on that testing, they actually estimated there were probably about 114,000 cases during that time. So 9,000 cases reported, but there were actually 114,000 cases. And in the table on the right, you can see that that effect was even more dramatic towards the beginning of the pandemic. in May and June, there were somewhere between 30 and 70 times more true cases than what had been reported. And remember, COVID testing was not readily available at the beginning of the pandemic, so there might be some testing bias, but also COVID is just milder in children, and so people were probably not just testing children as often.
Also, can you give me a cup of coffee here? Yeah, when you have it done. Yeah. Just black.
Okay, can we make sure we go on mute, please? There's only one speaker. Everyone else go on mute. Okay, go ahead, Marisa.
Next slide, please. So like I was saying, COVID tends to be milder in children. So this was a meta review looking at a lot of different studies. Most cases were asymptomatic or mild, very few severe or critical. Next slide. And this brings us to an important question, which is, given that children represent a minority of cases and that they tend to have a milder presentation, are they more or less contagious than adults? With other infectious diseases, usually children are more contagious. They're super spreaders, but it was never very clear if that was the case with COVID. The data is still a little mixed, but here's one study I'll share with you out of Wuhan, which was the city in China where the pandemic began. And they looked at household transmission. Depending on how old the very first case in a household was, how likely were they to transmit the infection to other people in the house? And as you can see here, if the first case in a house was less than 20, the secondary attack rate was about 6%. So that means that 6% of other household members became ill. Conversely, for if the very first case in a household was over 60, the secondary attack rate was 18+%. So as you can see in this sample, at least, if the very first case in a household was older, there tended to be a higher rate of transmission. So this is data showing that children really are not super spreaders. It's the elderly that would be. Next slide. And so that, of course, brings us to schools, because that was always the biggest concern. If children were super spreaders of COVID, could schools remain open and not, cause massive rise in community transmission? And there's a lot of data. A lot of it's global, since many countries never ended up closing their schools to the extent that we did in the US. So this is a report out of the WHO from last fall. And they found that based on a lot of different studies, there was a strong link between the number of outbreaks and local transmission. But schools being open did not lead to a rise in community spread where infection was low. So essentially, the directionality was always, if community transmission is high, the risk of school outbreaks was high, but not the other way around. So it's really community transmission driving school transmission with this disease. Next slide. Also, just interestingly, more outbreaks were reported in high schools than elementary schools. So even among children, the older children were more contagious than the younger children. And then in school outbreaks, it was more likely the virus was introduced by adult personnel. So transmission between staff was the most common. And in fact, this is actually what we've seen here at Children's Hospital. It's less of a patient to staff member transmission and more staff to staff, because this really is primarily an adult disease in terms of severity. Next slide. So I showed you some global data. Here's some American data. This isn't a peer-reviewed study, it's just pure numbers, but looking at schools that did remain open in the US during the first half of the pandemic, during that time, the student case rate was 15 per 100,000, staff was 24 per 100,000, and the community rate in those school districts was 18 per 100,000. So you can see that student COVID cases were actually lower than the community, whereas staff were slightly higher than the community at large. Next slide. Since, there is some data to show that COVID-19 is not transmitting successfully in schools. So here's one study out of a region in rural Wisconsin that had low community transmission. They looked at 17 schools that had some safety precautions in place. And during 13 weeks of in-person learning, they found that only 7 students and 0 staff were known to have gotten COVID at school. So this is an example of a setting with low transmission in the community where schools were able to successfully reopen without much of a risk with common sense safety measures. Next slide. And in fact, even when community rates are pretty high, schools have been able to reopen successfully. So this is a study from North Carolina. Between August and October, they had 11 districts open representing 90,000 students. During that time, 773 students acquired COVID in the community. Based on that number, researchers expected there to be 800 to 900 secondary infections in schools, just because they would have thought that one student would have infected at least one other student in school. But in fact, they only found 32 within school transmissions. So they expected 800 and they only found 32. And there were no child to adult transmission in the schools. And their safety measures were super basic. It was masking, distancing, and hand hygiene. That's really all it took to maintain a safe school environment. Next slide. So I've shown you some data showing that schools can reopen safely. Of course, there are limited situations in which there have been school outbreaks, but typically there were not great preventative measures in place. So here's one example. This is out of Israel in May of last year. They reopened their schools on May 18th. On May 19th, there was an extreme heat wave that led to the classes all moving indoors, so no one was able to study outdoors. And they were running the air conditioning at full blast, so it was just recirculating contaminated air. And predictably on May 30th, there was a large outbreak. So, not to say that school outbreaks never happen, but when they do, it's typically because preventative measures are not in place. Next slide. There's very limited data about the risk to teachers, but I've pulled some data from the UK looking at occupational risks depending on your type of profession. And they found for both men and women, the risk of COVID in teachers was lower than other professions, as you can see here. Next slide. And even among different types of teachers, there was no significant difference. So you were not really at a higher risk of acquiring COVID if you're a preschool teacher versus a university lecturer. So really what this tells us is that there's probably not too much of a risk to teachers. It's really just more about if you are a worker who has to go into work, you are at some level of risk, but teachers not seeing an overwhelming risk compared to other occupations. Next slide. So based on everything I've shared with you, the CDC guidance for safe schools is really pretty basic. It looks at your level of community transmission, and based on that provides recommendations. When community transmission is low, like I shared before, the risk is pretty low. And so schools are able to open safely in person with basic safety measures in place. When community transmission is high, that's when the CDC recommends more distance learning. And I will add a kind of caveat because this just came out yesterday, but there is new guidance from the CDC that all students and teachers, regardless of vaccination status, should be wearing masks at school. This is being developed as new guidance because of the more contagious Delta variant. Next slide. LA County guidance is all based on CDC guidance. You can see here what the basic tenets are. Next slide. So I've shared with you some data from international publications and from US districts. We don't have much data specifically about the safety of schools in LA County. And really the reason for that is because most students in LA have really not gone back to school. You can see that in the map on your left. Less than 20% of all LA students have actually returned to school during this pandemic. However, as you probably know, LAUSD is planning on fully reopening in the fall. So I think we'll get some data soon, but like I shared, I think as long as community transmission remains relatively stable and safety measures are in play, it should not be a huge safety risk for students or teachers. Next slide. And that's my slide deck. I'll take any questions if anyone has any.
Okay, are there any questions for Maritza?
Marissa, this is Andy Shen from Torrance Memorial. I think on your CDC slide, it said if there's high transmission, you mentioned that's when they recommend distance learning.
Yes.
Isn't the Delta variant leading to high transmission in LA County, and would that affect the reopening of the schools?
It's a really interesting question because you're right. We actually are, although California discontinued the tier system that we were using, if you look on the CDC website, LA County is now in that red tier. And so I will expect some update from, LAUSD and the other local school districts. It's very possible that they offer more of a hybrid approach in line with the CDC guidance, just because of this contagious Delta variant. So yes, I think we're in a very transitional time right now. It's hard to say what the school districts are going to do because you're right that we are in the red tier, and community transmission is quite high because of the Delta variant right now.
All right, if there are no more questions for Maritza, Marjorie Smallwood is going to be presenting on the pandemic and children's mental health.
Thanks, everyone. Same presentations I saw last week.
All right, thanks, Marissa. Thank you, Essence. Just a quick update, if we could go back. As a disclosure, I have no conflict of interest in relation to this presentation. I just want to highlight that new data highlighting the impacts of the COVID-19 pandemic on the mental health of children is starting to emerge. So this presentation is subject to change. If you could go back one slide previously.
Sorry, I'm having a hard time with the back. Okay.
If you scroll down, there we go. Perfect, thank you, Essence. And one more forward. All right. So quick introduction. This topic of the COVID-19 pandemic and children's mental health is one that's difficult and complex. With the pandemic, we are seeing heightened awareness around the issue, and unfortunately increased prevalence and severity from what the data is starting to indicate. And I did want to start off by highlighting a comment from Dr. Lee Beers, the president of the American Academy of Pediatrics, who stated that poor mental health may turn out to be one of the most prevalent long-haul symptoms of COVID-19 in children, stemming from the indirect effects of the pandemic. So we'll talk about some of those elements briefly here today. Next slide. So pre-pandemic prevalence, looking at the percentage of some form of mental illness within pediatric patients, children. So even before the pandemic, many children in the US, as you can see here, were living unfortunately with some form of mental health disorder. On average in the years 2018 and 2019, among children ages 3 to 17, about 8% of children, so that's about 5.2 million children roughly, had some form of an anxiety disorder. And 4%, that's about 2.3 million, had a depressive disorder, and 9%, about 5.3 million, had some form of attention deficit disorder or attention deficit hyperactivity disorder. And I'll highlight some of the core groups in particular with regards to demographics and higher vulnerability and prevalence. Adolescents in particular, we've seen increases in poor mental health outcomes in recent years. Next slide. And I apologize, folks, if I come off muffled, that's just because I'm in a location that's a shared space. So I am wearing a mask today as I give this presentation. So just stop me if you're unable to hear me clearly as I present today. Looking at some of the psychosocial stressors in COVID-19, we know that there were a number of indirect effects of the COVID pandemic and direct effects. There were abrupt disruptions to daily life, increased social isolation with the disease transmission mitigation measures, the stay-at-home orders, loss of loved ones, financial insecurity, disruptions to childcare, interrupted or limited access to school resources. So I'll talk about that a little bit more with regards to mental health resources that are provided in our school environments, increased food insecurity, impacts of personally mediated and systemic racism, social media, which is a double-edged sword. While on one level it provides some level of socialization for children, there's still bullying and a number of issues that occur there online. Indicators of increased substance abuse, and also media reports of a rise in parental abuse and neglect, although I haven't been able to find any studies to substantiate those media reports at this time. Next slide. Looking at it by age group, so young children in particular, as you can see, one of the surveys of children, parents reporting worsening of mental health for their children ages 5 to 12 through the pandemic. We saw 22% of parents were reporting that they saw an overall worsening of mental or emotional health within their children during the course of the pandemic in 2020. elevated symptoms of depression, elevated symptoms of anxiety, and elevated symptoms of psychological stress. So I'll kind of toggle back and forth based on what the data that we are able to look at this point in time to really see that prevalence and severity has been increasing pre-pandemic and over the course of 2020. Next slide. Looking at adolescents, this is an age group, once again, in particular, that we've seen increase in mental health concerns. And I'll talk about that a little bit more with regards to our specific hospital data down the line. And in particular, what we're seeing with regards to suicidal ideation and suicidal attempts. So pre-pandemic, we saw a significant increase over time over the last 10 years between 2009 to 2019. Showing an increase in suicide attempts and suicidal ideation over time. And that's one of our core behavioral health concerns in patient populations that we're seeing at our hospital at CHLA. So I'll talk about that a little bit more. Next slide. I just wanted to take a moment to also highlight particularly vulnerable populations as well, not just by age group, but children of color, as we know, are disproportionately affected, were affected and are affected by the pandemic. Face more barriers with regards to access to mental health resources. With the school closures, they experienced limited or suspended access to school resources, higher rates of illness and death from the COVID-19 pandemic in Black, Latino, and Native American populations. The effects of structurally and personally mediated racism has also been associated with poor mental health outcomes, and we did see an uptick in hate crimes over the course of 2020. Next slide. LGBT youth as well. There was a significant amount of pre-pandemic prevalence, and we're starting to see indications of increased rates among this specific demographic as well. So among high school students, once again, adolescents who identify as lesbian, gay, or bisexual, transgender, or queer, were reporting mental health distress or substance abuse use in 2019. Looking at the studies, we saw 66% reported, self-reported persistent feelings of sadness or hopelessness. 48% considered attempting suicide in the past year. 27% illicit drug use. And so substance abuse and self-reporting of some form of mental illness was pretty prevalent already at the time. So it is a particular group of concern. Next slide. So looking at it from the perspective of our hospital data, what we're starting to see, once again, there's very limited reports, unfortunately, that really highlight clearly the data indicating rates of mental illness amongst our pediatric populations. But from April to October in 2020, hospitals across the United States saw a 24% increase in the proportion of mental health related emergency department visits for kids ages 5 to 11, and a 31% increase for kids and teens ages 12 to 17. So once again, highest among our adolescent populations. Next slide. And one of the most prominent reports published by the CDC's MMWR highlighting sort of our ED visits and the trends over the course of 2020. So as you can see, and as we all directly experienced within our hospitals, at the initial start of the pandemic during the stay-at-home orders, our number of ED visits significantly dropped during the initial weeks of the pandemic. But over time, when you look at the proportion of mental health related ED visits per 100,000 pediatric ED visits, so essentially looking at injury related ED visits versus behavioral health related ED visits, we saw that there was an increase in the number of mental health related ED visits over time, significant increase, excuse me. Next slide. And once again, highlighting that by age, as you can see, I'll start from the bottom to the top. Adolescents accounted for the largest portion of ED visits, followed by children ages 5 to 11, and then children ages 0 to 4. Next slide. So with regards to the visits and what we're seeing at Children's Hospital of Los Angeles, We have seen an uptick in the number of patients presenting with suicidal ideation or suicidal attempts, eating disorders. Those are the primary complaints that we're seeing at our emergency department. And this is a trend that unfortunately is occurring nationally. So we're starting to see an uptick in those patients that are presenting with suicidal ideation or suicidal attempts, so increase over the course of 2020. And I'll highlight in the next slide. Don, I'm not sure if the folks on the call were aware, recently for the state of Colorado, the governor declared a state of emergency due to the uptick in suicidal ideation, suicidal attempts, the number of pediatric ED visits that went up over the course of 2021. So due to a lack of bed capacity, staffing resources, et cetera, the Children's Hospital of Colorado worked with the governor to declare a state of emergency to address this growing need. Their pediatric ED visits went up by 72% over the course of 2021. And during the month of April alone, they were up by 90%. So this is an area of concern that we're constantly monitoring at this time. Looking at the system stressors, so issues that are affecting this current state. So there's still a continued gap between inpatient psychiatric care and weekly therapy. So that's partial hospitalization or behavioral health therapy programs to help bridge and provide additional support. There's still gaps in resources there. Telehealth, while we advanced significantly in launching a number of telehealth resources over the course of 2020, we do know that studies are indicating it's not effective for all. And once again, a lack of access to resources means it's not accessible for all. So there's still continued gaps there. And then across the country, we still continue to experience psychiatric bed shortages for our children in crisis. Next slide, please. So CHLA efforts. So as I mentioned previously, we have seen an uptick once again in patients presenting with suicidal ideation and suicidal attempts. So we have instituted universal screening for self-harm. We have also continued to coordinate direct care with our families in support of these patients and are continuing to review opportunities to expand our resources. So learning from other children's hospitals, CHOC has some great best practices that we've looked at in how we can expand our care areas and staffing to address these specific patient populations. Disaggregating our data to also review other elements that may be affecting this patient population in our care resources at the organization, including disaggregating by race, ethnicity, and other metrics, and focusing on improving equitable and culturally appropriate access to care through our programs here at CHLA. Next slide. So while we do know that there may be forthcoming changes with regards to school reopenings in Los Angeles County, we're still in a bit of a holding pattern. Schools are a first line source of mental health support in Los Angeles County. And in the spring, the LA County Board of Supervisors actually approved additional funding support for LA County schools to address this growing demand and need. And so they directed the LA County Department of Mental Health and the Office of Education to work together to build out additional mental health resource toolkits, including trauma responsive training for our educators and our staff and our schools in predicting and supporting the increased demand that they will see in the fall and what they're currently experiencing. Next slide. So I just wanted to close with highlighting the renewed focus and providing some additional resources for our hospitals and our healthcare partners here today. So on a positive note, and what gives me hope is that unfortunately, the pandemic has put a spotlight on children's mental health. There was a significant amount of pre-pandemic prevalence. Once again, data is starting to indicate increase in mental health demand and need for resources. And so we continue to look at opportunities to expand access to resources in the provision of care, monitoring our data, looking at national trends and different best practices from our colleagues so that we can ensure and enhance our availability and access to care. And just closing by highlighting that intervention, once again, may preempt more severe mental health leads later in life. So early intervention is key. Next slide. So I'll close by highlighting some additional resources. I've had many conversations in preparing this presentation today with our Department of Mental Health in LA County, other hospital partners, psychiatric services, and other care areas throughout our hospital. And some of the resources that they advocated for and wanted to make sure we were sharing with our hospital partners included highlighting the LA County Department of Mental Health helpline. So encourage everyone to keep this information readily accessible and posted, not just for our patient populations, but for our staff. It's a 24/7 hotline for LA County residents seeking assistance in crisis and access to local mental health programs and resources. And then there are some additional educational resources on their website dedicated to COVID-19 education, but also suicide prevention and anti-racism. And lastly, Headspace. So Headspace is a fun one that is essentially a mindfulness training resource free for all LA County residents through September 2021. And with that, I will close and see if anyone has any questions.
Hi, how are you? Are you looking for the restroom? Okay. Yeah. What
Okay,
class
are there
you here
any
for?
questions for Marjorie? And if you're not asking questions, please go on mute.
What unit do you work on? What unit? Oh, okay. Oh, here you go. I'm so sorry about that.
Okay, if you have any questions for Marjorie, go ahead and unmute yourself. I've muted everyone.
And I can leave our new CHLA emergency management email address in the chat. So if there are any follow-up questions with regards to Marissa's presentation on COVID-19 and school reopenings, or my presentation on the pandemic and the mental health effects on children, please feel free to email us at any point in time, and we'll be more than happy to get back to you as quickly as possible. Just wanted to thank everybody for your time today, and wish everybody a great afternoon.
Okay, thank you so much for joining us this morning, Marjorie, and thank Marissa as well. All right, and then I'll also send the slideshows that both of these presenters provided for you guys today. So just look for that in the follow-up email for this meeting. So we'll go ahead and begin our updates. Do we have anyone from California Hospital Association or HASC? Or Chris from EMS agency?
Hi, good morning, Essence.
Good morning.
Yes, so I will speak to what HASC would say. Mary usually reminds people that the CHA conference is scheduled for September 14th and 15th. It's going to be virtual. It's free to members. So it's pretty simple to register for it, and they'll provide you that link right away, or the confirmation. Also, she typically will announce that if you are looking for HICS classes, reach out to Mary Massey or Ryan Burgess, and they are still providing virtual HICS classes, and they typically are on Fridays. Now just an update from us, if you have, the audits were completed in June, the last ones were in June. So if you have an improvement action plan for Isabel, be sure to complete it and submit it to her. Also, Terry sent out the FAFATA, is a federally funded Accountability and Transparency Act. That was from the federal government, which requires facilities to report their funding. So be sure to complete that and send that in to Terry if you haven't done that. It's due on the 30th, which is a couple of days away. Be sure that that gets done. Also, just a reminder that next month, or an informational update regarding the single audit questionnaire, the A133, which many people confuse with the FFATA. That's going to be coming out in August. Terry will be sending that out, and you have to acknowledge it. This one is a little particular because it's based on your size of your organization and how much funding you get system-wide. So some of you may need to send this to your finance department and get that completed and signed off. So be on the lookout for that, and don't mix them up with the FFATA. Many people do. So this is why he typically sends the FFATA for July, and then in August he sends it out so that they don't get confused between the two and say that I've done one and they're confused over that EMS. So just for an update on that. HDMT was a hit in May. We had a large showing, over 200 people participate. We are planning to host the HDMT virtual again now that the Delta variant is changing the way we do business again. We are going to host it October 5th and 6th virtually. I'll be sending that out in the end of August, the link to all the EMOs, and then you can share that with your staff and other personnel. This one's, all the virtual HDMTs are free, so it's a great opportunity for those surgical centers, long-term care facilities, those facilities who don't receive funding directly from HPP, that you can take this class for free. Typically, that class will runs you about $200, and it's a 2-day course and primarily an 8-hour day. So what we do virtually is we cover all the lecture components. We take out the hands-on and also the exercise component. So it's very beneficial. It gives you an overview of our system and the hazards that we have throughout our system that we should prepare for. Also, we have the National Healthcare Coalition. It's going to be in Orlando, Florida, November 30th through December 2nd. We do have 2 entities that are presenting at that conference. We will be presenting how we distributed the PPE, best practices, and also Steve Storbakken from Pomona Valley Hospitals will be presenting on access and functional needs presentation that he's been working on a project for several years now regarding access and functional needs. And just an update from us, we are going to look at the burn surge plan and update that. Be reaching out to those volunteers at the trauma centers that volunteered to participate in that process. I'll be sending out a doodle poll so we can get a meeting going this week. And that should get the process going. There was one other thing. There's also a survey that went out to facilities. That was more of an after-action report to SurveyMonkey. That's due at the end of this week on Friday. So be sure to complete that so you can be compliant. We are finalizing our scope of work crosswalk. Last year we modified the scope of work, and we needed to provide additional information or for like the scope of work. So for instance, this year we canceled the decon training once again. So we're gonna, in lieu of that, we need to do something else, or it may just be waived. So we are looking at some of those items. For instance, the business continuity plan workshop. The hospitals would typically get like $5,000 to attend the business continuity plan. And so what we're doing is having you submit another document in lieu of the business continuity plan. That falls in line with business continuity. So what we're looking at doing is, for that particular item, is having the EMOs develop a desktop procedures for your emergency management component, what you do for HPP, how do you fulfill those grant requirements. The reason why we're looking at that as an option is, as the county, when there is turnover at your facility, many times people will reach out to us and like, well, what do we do here? I don't know what, there's no really good handoff from one EMO to the next. And especially if you've worked for the county, usually you would have to vacate your position before they can hire someone else. And so there's never a really good handoff. No one really knows what you're doing, and all the institutional knowledge goes with you. So I'm sure it happens in the private sector as well. So that's what we're trying to do, is help that next individual and as they transition into that new role as an EMO. Any questions on that? Also,
sorry, Chris.
Go ahead.
This is Andy Shen from Torrance Memorial. So instead of a business continuity thing, we're going to submit EMO continuity desktop procedure.
Yeah, so we'll give you some instruction. We'll give you an example of it. We're just going to finalize that the crosswalk this week, and then I'll send it out, and we'll send you a template or an example of what we're asking for.
Thank you.
So Chris,
so what we're going to do is, as you submit it, we'll put it in your file. So for Torrance Memorial, we'll put it into your file here on our end, like Isabel will put in your file. And then when there's a new EMO at that position, then they're like, well, I don't have a document. I don't know. I'm kind of new to this. I'm learning. And I go, oh, well, here's your desktop procedure. This is what you're supposed to be doing on their end. And every facility will be different. We're having to do it. We're actually tackling that here at our agency or our department. We're writing up desktop procedures as people start. There's going to be a large change in our agency because there's going to be a lot of retirements, and so we're anticipating a lot of institutional knowledge being retired with those individuals. So what we're trying to do is capture the process as much as we can. Any additional questions?
All right, thank you, Chris. And then we have Keith on from Public Health. If you can go ahead and give us the public health update.
All right, double unmuted myself. Can you hear me okay?
Yes, thank you.
All right. Essence, would it be okay if I shared my screen?
Oh, sorry. That might be a little difficult. If you have slides, if you could send it to me, that would be easier.
I do not have slides, but okay, that's fine. I don't have to. I'll just read. I am going to post into the chat, though, for everyone, some links, just so you have the links for the information resources that I'm about to talk to, or at least for some of them. So you'll see in the chat box now some of the links. So, okay, let me begin. All right, so first, I just kind of want to discuss a little bit about some of the updates from public health. Again, I'm Keith Gertzweiler. I'm a liaison public health nurse from the Acute Communicable Disease Control Program. ACDC has worked a lot on COVID. But that said, we actually have a sister program called Vaccine Preventable Disease Control, and they have been really the ones who have been working on the vaccine component, both the distribution and also like the data and so forth. So I'm not a member of that team. I'll do my best to give updates here. If anyone has any specific questions, I'll do my best to answer them and or to go back to that program and see if I can get some more information. So in no particular order, I was just going to start. So first, you may have heard that the state health officer released a health officer order on Monday, July 26th, essentially stating that that the healthcare workers in acute care hospitals, skilled nursing facilities, intermediate care, congregate care, correctional facilities, dialysis, hospice, acute psych, and so on, will start to have to track and verify the vaccination status of all of their healthcare workers. All healthcare workers must continue to follow respirator and masking mandates. Healthcare workers who are unvaccinated or partially vaccinated, meaning they're not fully vaccinated, must be tested once weekly or twice weekly, depending on the setting in which they work. So for example, acute care hospitals would be twice weekly. And healthcare workers must follow all other infection control practices. So in the links I posted in the chat, there is a link to that health officer order. Now, the state Department of Public Health, California Department of Public Health, is saying that some all facilities letters are supposed to come out to address on perhaps a little bit more granular level exactly what this would entail, when this would be effective, and so forth. And as of this meeting, I have not seen any of those all facilities letters. But this is just kind of very top level information that we can share, and we wanted to be sure to share it with our partners in the DRC. There's a lot more information, as you can see when you read through the letter. This is like extremely high level. So moving on, the second link I shared was from our LA County Public Health media page. So again, this is all public facing information, but basically yesterday, July 27th, LA unvaccinated and partially vaccinated persons are suffering greater illness, hospitalization, and death from COVID-19. Yesterday, again, 2,067 new confirmed cases and 15 new deaths. On the preceding day, July 26th, COVID-related hospitalizations in LA County have nearly doubled in 2 weeks. So you have the media page, and that link will show you the different press releases. It looks like they're almost daily to give you and your facility kind of an up-to-date snapshot of what's happening right at that time. It's a really good thing for someone in your facility to be following. Then I gave you a link to our vaccine dashboard. So this is just going to give you the global data on COVID-19 vaccinations in our county. So this is updated through Monday, July 26th. And that was when the dashboard was updated, but the data only go through July 23rd. So as of July 23rd, 10 million, almost 11 million doses have been administered. And then it breaks it down into first dose and second dose, which would apply to the to the Moderna and the Pfizer vaccine versus Johnson & Johnson, which is just a single dose. So of the 10.9 million doses administered, 4.8 million of those are second doses. And then residents age 16 plus with at least one dose, we have like over 5.8 million. So 70.7% of our residents age 16 and older have at least one dose. Fully vaccinated, we're at 5.1 million plus. I'm giving very rounded numbers just for the sake of time. And amongst seniors age 65 and plus with at least one dose, 88.5% of our seniors in our county have received at least one dose. And fully vaccinated seniors, we have 1.0 plus million seniors. So you can look at more granular details about with the vaccination. And with that second link as well, one thing that's really good, again, I'm sorry I can't share my screen. There are maps that go by like Torrance and Carson, Redondo Beach, and so on. So you can actually click on a map and get the data for your neighborhood, your catchment area in the South Bay. And so you can kind of get a sense of how your communities and the communities you serve, like how are their vaccination rates and so forth. So it's a really good link to bookmark as well. Okay, so moving forward, I also then included a link to the reopening dashboard. Now this is where you can find, excuse me, this is where you can find information and data on post-vaccination cases, hospitalizations, and death. So if, again, on your own computers, if you want to click on that, you can scroll down and there's a little plus sign on the right for different sections. So there's one table called cumulative post-vaccination cases, hospitalization, and deaths by report date. And because it's cumulative, essentially this is a running total. So as of July 20th of this year, amongst the fully vaccinated, and this excludes Long Beach and Pasadena, which have their own health jurisdictions. So we have 4,855,839 fully vaccinated persons as of July 20th. So that would essentially be your denominator data. Amongst those fully vaccinated persons, there have been 6,520 cases. So this would kind of be your, when people talk about breakthrough cases. So that is 0.1342%, so less than 1%. Amongst that fully vaccinated hospitalizations, only 287 of that 4.8 million. So that's a 0.0059% rate of hospitalization amongst the fully vaccinated. And deaths would be 30 as of July 20th. So that is a 0.0006%. So, we're looking at thousandths or maybe, 10 thousandths of a percentage. So 30 out of 4,855,839. Now, I am not a subject matter expert, so I cannot discuss, I don't know what we know about those 30 cases. But anyway, so there is some data for all of you. Moving on to some other, let me switch screens here. So I'll go over the highlights from July from ACDC. So there have been 3 cases of melioidosis in patients, none in California to my knowledge, but 1 in Kansas, 1 in Texas, and 1 in Minnesota. So the CDC issued a health advisory about these 3 cases of melioidosis in patients who have no history of travel outside of the continental US. The reason that's significant is because typically this is an infection we see in Australia, Southeast Asia, and other parts of the world. I think the only part of the United States where there is endemic melioidosis is in Puerto Rico. So this is a bit unusual, but the symptoms are very nonspecific. They could include pneumonia, abscess formation, blood infections, and others. Sometimes the disease could be mistaken for TB, and so the correct treatment could be delayed. So we sent out an LA HIN to the infection preventionists in our county. And also you'll notice, in the chat links, I did put a link, for the LA HIN. And I do recommend that everyone on this call should go and sign up to receive the LA HINs. We do often send them to hospital, nursing home, infection preventionists. But again, anyone in the public can sign up for those, and you'll get very timely information from public health. Moving on, so there has been an increase in interseasonal RSV, or respiratory syncytial virus, in parts of the southern United States. RSV can be very serious, especially for younger people and for older adults. And obviously healthcare workers should not work while ill, even if it's not COVID-19. If it's some other respiratory illness, they should stay home. And so we sent this information out again to providers that they should consider RSV in patients who present with upper respiratory symptoms who test negative for SARS-CoV-2, they should be considered for RSV testing as well. And I think just for the general public, it's a good reminder that there are other diseases besides just COVID-19. There's influenza, colds and so forth. So just, maintaining good hygiene and good infection prevention and control is very helpful. Moving on, there has been an increase in antibiotic-resistant Neisseria meningitidis. So specifically, penicillin and ciprofloxacin-resistant meningococci. And so this has been seen in the United States since 2013. And basically, the CDC and the state are recommending that for different Neisseria meningitidis isolates that are found, that providers also order antimicrobial susceptibility testing to help guide treatment and so forth. I'm not going to sit on this topic for very long. If anyone has any questions, you can let me know and I'll be happy to give you more specific information. As it's summertime, we should expect to see West Nile virus. So typically we see West Nile in the summer and into the fall. So patients who present with kind of a non-specific febrile illness, who also present with aseptic meningitis, encephalitis, or acute flaccid paralysis should be considered for testing for West Nile virus. Also in previous years in our county, we detected St. Louis encephalitis virus in mosquitoes. So, in the instance that West Nile virus testing would be negative, St. Louis encephalitis virus is another possible test that providers should consider. And serological testing for both infections is available at commercial laboratories, not that public health is endorsing any, and also at no cost through the Los Angeles County Department of Public Health Laboratory. So again, if anyone has any questions, please reach out to me or your assigned liaison public health nurse, and more information can be given to you.
Okay.
We have a new red cap. Yes.
Oh, just real quick, Jennifer Ray from South Bay, one of our clinics, is asking if the health order is applicable to community clinics regarding the mandate to track vaccination status for all staff and test the unvaccinated.
So I will quickly read. Here's the list. Again, I can't show you my screen, but the list on the order. So there's 3, A, B, and C. A would be acute healthcare and long-term care, so general acute care hospitals, skilled nursing facilities, including subacute facilities and intermediate care facilities. B is high-risk congregate care, such as adult and senior care facilities, homeless shelter, and state and local correctional facilities and detention centers. And C are other healthcare settings. So let's see if it's on there. Looks like it might be. So we have acute psychiatric hospitals, adult day health care centers, adult day programs licensed by California Department of Social Services, program of all-inclusive care for the elderly, such as PACE and PACE centers, ambulatory surgery centers, chemical dependency recovery hospitals, clinics and doctor's offices, including behavioral health surgical, congregate living health facilities, dental offices, dialysis centers, hospice facilities, pediatric day health and respite care facilities, residential substance use treatment and mental health treatment facilities.
Thank you, Keith. So basically everyone on this call.
Sounds like that, yeah. So Candida auris, again, I'll try to keep this fast, but you've heard us mention in previous meetings over the past couple of years, Candida auris is a highly resistant, high morbidity, mortality type of fungus. It's especially serious in healthcare settings and for patients and residents of subacute units like ventilator SNFs and long-term acute care hospitals. And after a year of aggressively working with our healthcare facilities in our county to detect and contain Candida auris, the number of cases has gone up, unfortunately, during COVID. I think we have over 500 some cases in our county. So we sent out information to our facilities that we will no longer follow up on discharges specifically from facilities having an outbreak or transmission. We are going to be sending surveys to our hospitals and nursing homes. Basically, each facility will get a survey that they have to respond to every week about any cases that might be in their facility. Public health will no longer be doing admission screening, so facilities can use their own reference labs, and we have shared information on labs that can perform that. Again, we don't endorse any specific lab. We're just sharing information on how people can process tests. And then effective September 1st, patients and residents coming from long-term hospitals like LTACs and the subacute units of skilled nursing facilities, or VSNFs, are considered coming from high-risk facilities for Candida auris specifically. And then if there's any kind of outbreak or transmission in a non-high-risk facility like a hospital, then they would be listed in our little weekly update to infection prevention as by name. So there's a lot of information on our website. If anyone has any questions about Candida auris, please reach out to me or your assigned public health nurse. We can get you information that might be more applicable to your health setting. And last, actually not last, sorry, second to last, there's an increased risk of rabies exposure. So as everything is opening back up, people are traveling, going to national parks and campgrounds. People might come into contact with wildlife more frequently, and certain animals such as bats, skunks, raccoons, coyotes, foxes, possums, and others could potentially be infected with rabies and be exposed if they were bitten or something like that. So we have a veterinary public health website if anyone wants any further information. All animal bites do need to be reported to public health and specifically to veterinary public health. There is information on our website about how to report animal bites. But again, if you have difficulty finding that information, or I'm happy to send you links if anyone wants any further information. Other health alerts that went out recently, sorry, it's been a busy month, reminds us that there's not just COVID in the world. Mid-July, we sent out a health alert about monkeypox. So very briefly, there was a US citizen who traveled from Lagos, Nigeria to Dallas, Texas via Atlanta on 2 separate flights on July 8th and 9th. And this person was diagnosed later with monkeypox. The rash had begun on July 7th, 1 day prior to travel. And so public health sent out information to providers about monkeypox and symptoms, including malaise, headache, muscle aches, and so forth. Anyway, there's a lot of information there. It's also on our LA Hunt website if you want more information. And then we sent out yesterday a CDC health advisory about vaccination to prevent COVID-19 outbreaks with both current and emergent variants. But basically, we're reminding health practitioners and clinicians about the urgent need to increase COVID-19 vaccination coverage across the US to help reduce morbidity, mortality, also to prevent overwhelming healthcare system and to lessen health disparities. So anyway, there's a whole ton you can read about that. And then lastly, we sent out information about a recall of a blood lead test. So there was a recall of LeadCare blood lead test. Both Magellan Diagnostic and the US FDA issued this recall. This was early in July 6th. That LeadCare blood lead test that were distributed between October of last year and June of this year must have been recalled due to the possibility that they could cause serious injury insofar as they might underestimate serum lead levels. So this information is also on the LA Hunt link that I sent out. Lots of information. Thank you so much for your time. And if anyone has any questions, I'm happy to answer them.
Okay, are there any questions for Keith?
Hi, this is Roy Martinez at Heritage. I had a quick question for Keith. So with the Delta variant coming out, I know that there's a mandate to find out about vaccination status. How about talks about the mandate for actual vaccination in facilities, in healthcare facilities?
Yeah, I don't have any information on that in our county. I've heard that certain health facilities are looking at that option, but the county does not currently have a mandate to vaccinate, at least not county. There's nothing like that countywide. I've heard through the mainstream media that other government entities are looking at implementing that, but I don't have anything that for the county mandating that.
Thank you. And also another quick comment that, with everything going on with the Delta, finding out that it's more transmissible, all the data that was shared earlier with the different speakers are, very much appreciated, but I don't know if it's going to still be applicable, especially with the kids, with this new virus, the variant, the Delta. It's affecting not only the unvaccinated, but even the vaccinated. A lot of vaccinated people who are still getting positive. So it's just scary. It's scary for us in the facilities and skilled nursing. It's keeping us awake at night because, like, for example, the visitation, we've opened up the visitation, per the, guidelines provided to us. But now with everything going on, we're kind of scared, and we're trying to see if any kind of new guidelines might be coming up from the county regarding visitation or dining together, communal dining, stuff like that. So just wondering what your thoughts were. Thank you.
Yeah, my pleasure. I'll take those questions and those concerns back to my team. I'm sure many of you know Dr. Zach Rubin. And also we have different long-term care teams, both skilled nursing and congregate care. So I'll take your questions and concerns back to them, and in the possibility that the county might offer additional guidance. Thank you.
Okay, thank you. And just remember, that's why they're wanting us to put the mask back on. CDC just did a press conference yesterday where they did talk about some of that and how there is some breakthrough infections with even those who are vaccinated. They've been doing studies to do a deeper dive into why that is. They're finding that there are some people who, even though they're fully vaccinated, just their bodies did not respond, like maybe because they do have a history of being immunocompromised. And so they're still able to get the virus and possibly spread it, but the severity of their own illness is not as bad. So there is some breakthrough. So just remember, that's why we're being asked to put the mask back on, because of that. So, still continue with the social distancing and stuff. I do want to get to our updates for our facilities so we can touch bases. We have in the past done weekly check-ins with the hospitals. We may go back to that. I wanted to discuss that in this meeting, but first I just want to do the updates. So we're going to go around, we'll do hospitals and then hospitals, and then we'll do Jeff with the city, and then we'll do our long-term care facilities and then clinics. So for Harbor, we're currently doing business continuity planning, just fleshing out more of our plans. The county has provided us with the consultants, so we're working with them to do to really just get a deeper dive into our business continuity planning and be more comprehensive. We're also doing planned power shutdowns. We have a series of different things that we're doing for the we have a building that we are building again. So our new building. So some of the things are to do that, and some of it is to replace old oil switches. And so we have a series of shutdowns that we've been doing even before the pandemic and through the pandemic. And now that's basically been our life, is every Saturday we spend at Harbor doing these plant power shutdowns. And then we are also planning an exercise. So even though the state has canceled the statewide exercise, we are still planning a full scale. You know, even with COVID, there are still different things that could happen. Us being California, we're still at risk for an earthquake. And then, so how do you deal with an earthquake while still having to deal with the pandemic precautions and make sure that you're still doing social distancing and, you know, infection control protocols? And so we're going to be planning a full scale exercise with that deals with the earthquake scenario that involves evacuation, as well as incoming patients that self-present. And then we're, for our COVID status, so with our updates with everyone, I'd like you to also provide a status of how you're doing with the current kind of uptick in the COVID numbers. For Harbor today, actually have our numbers from yesterday because today's numbers haven't come in yet. So as of yesterday, we had 21 inpatient COVID patients. 5 of them are in the ICU. 1 is a pediatric patient. And we haven't really been having challenges with supplies or anything else. The only concern that we currently have is that some of our RT registry staff have been deployed to other areas. They've taken on travel assignments in other areas where COVID is more prevalent and hospitals are having a bigger surge. So we are kind of, you know, a little leery about that, because during the pandemic at its peak, earlier this year in the winter in January, we did have a huge need. We actually had a lot of registry RTs come on board to help us out. So we're a little leery letting some of them go. So that's our concern, is more so potential personnel shortages. Jeremy, are you on from Low Company? Or sure, Dr. Schlesinger, did you have anything to add for Harbor?
So yes, I apologize. It's a little loud where I am. So I will give a little revision. Actually, the numbers just came out for Harbor for today. We're actually up to 26 inpatients. This is obviously concerning. The rate of increase throughout the county, as Keith was kind of alluding to, is somewhat alarming. And while the vaccination status is very highly protective against severe or hospitalizable illness, there are so many people that are not vaccinated that there are some limitations to how effective this may be in preventing surge. We are seeing this at all of the DHS hospitals, and I'm presuming at a number of your hospitals as well, although the rate of increase of hospitalizations is much lower than we saw in the previous surge. That being said, what most hospitals I've spoken to are seeing is that they have a shortage of staff, a large increase in general volume of patients requiring evaluation in their emergency departments or admission, and a concomitant, mild surge in COVID patients requesting care. This is going to lead us at Harbor actually to reconvene a group of emergency physician folk that we had started to meet with in December and January to see if we can kind of schedule early alerts for when hospitals are getting overwhelmed with patients for whom, particularly for COVID, they do not have the capability to care for them, specifically higher level of care patients. So, if you are from one of the community hospitals in the area, and I specifically mentioned the Little Company of Mary's, the Torrance Memorial, and Memorial Gardena, that have a little bit less on terms of overall resources for care of ICU patients, please be aware we'll be reaching out probably in the next week to talk about how we want to communicate as facilities in case we need to offload EDs and ICUs. And that's it for me. Thank you.
Thank you, Shira. So we will be reaching out to you guys and reconvening our kind of weekly check-ins. And so just look for that. Um, Little company, Jeremy, are you on?
Yeah, so for COVID status for Torrance, we have 15 admitted, 3 in our ICU and 2 of them on mechanical ventilation. San Pedro, we're at 18, 4 in the ICU and all 4 on mechanical ventilation. We were in the process of attempting to do a non-COVID related disaster drill this month, but we've tabled that and have postponed it to see if we continue to see inclining numbers. Last week, we did see, early last week, we doubled our numbers in-house. We've kind of seen that just stay steady and decrease a little bit, but all of our predictive models that we have from our internal data, as well as looking at all of our ambulatory data for just symptoms that we see in our EMR system is, we're anticipating a further surge. So we've reconvened our command center for COVID and have been working on all of our protocols. We've, have assigned our COVID units again, and then our expansion plan should we see that surge. As an organization, we are working on staffing as well, like everyone else. I think all the travelers made their money last year and have selected to take off, or, we also see that big exit of healthcare workers leaving the field just because of the traumatic experience that this pandemic has played on them. So that's kind of where we're at currently. And then we're just, our big focus as well is now making sure that we come into compliance with the new health officer order that was issued regarding all of the testing of unvaccinated individuals. So that is the big focus at this current moment.
Okay, thank you, Jeremy. Dr. Shin, are you on from Torrance?
Yeah, I'm on. I'll let Christine Sarah start out. She's our new emergency manager.
Yes.
She
Thank you,
replaced
Christine.
Cheryl.
Welcome for joining.
Hi, everyone. I'll start out with our numbers. As of yesterday, we did have 27 COVID confirmed admits. 26 of those were in isolation, 4 on vents. We're at 94% hospital occupancy and 90% occupancy in the ICU. Yesterday, we did have 44 out of 263 ER visits, all COVID related. Regarding vaccination policy, I know everyone was sending their policies out. We're actually meeting today at 11 o'clock to discuss the policy we're hoping to put in place for our facility here. So I can't give details on that yet. I don't believe we're ever going to probably put up tents, hopefully not. But I do know that last night we did have a very busy ER and we did dedicate one of our pods to strictly COVID again. So we do have a COVID pod. Other than that, I don't know if Dr. Shen can give any more details.
Thanks, Christine. Yeah, one thing we're going through is kind of what Chris Sandoval was bringing up with the EMO desktop procedures, where we changed to EMOs and we lost a lot of institutional knowledge in that transfer. So we're trying to, get the new program up and running. So that's a big thing we've been dealing with. Other stuff is pretty much similar to what Dr. Schlesinger and Jeremy from Providence were mentioning. The difficulty about this Delta variant surge is that our hospital is now very busy with high volumes and high acuity, which is a different situation from the winter surges where at that point there was a kind of a low ER census, low hospital census. Now we're starting off with a high census, high acuity. So we're watching that very carefully. We've reactivated the hospital command center due to the Delta variant surge. We're going to have our first command center meeting this Thursday. We've continued our ICU triage teams throughout the past months because we felt that it was a good practice to maintain ICU output. But given the variant surge and now our ICU is at 92% capacity, we're going to increase our triage team meetings, palliative care team meetings from 1 time a week to 3 times a week. Yeah, that's what we got. Thank you.
Thank you, Dr. Shen. Maurice from MLK.
Good morning. Happy Wednesday. Similar to what you're doing over at UCLA, I'm very in the same place with working on BCPs. I'll be very interested to know. You said you had a third party coming in to help you with that?
Yes, so there's some hospitals that have gone with a consultant. So with our, we're an enterprise with different facilities, so we're kind of sharing a consultant.
I'd be interested to talk to you about that offline. Also, we're doing a drill for the same exact reason that you mentioned that you're doing the drill. So we have a small planning committee getting together actually this week to work out details of the drill. We are trying to get something called ADAP certified. So we don't have a pediatric unit here. So however, we have to include it into our drill. That's a big deal for us. We are considering reopening our hospital command center for COVID. I guess we're all on the same page when it comes to that. We also instituted a visitation vaccine. So any visitors coming to the hospital have to show proof of vaccine, or we're not allowing visitors unless it's end of life or beginning of life. So somebody's dying or having a child. Outside of that, just visiting, if you're not vaccinated, we're not allowed at this time, subject to change. And that's all I really got so far.
All right, thank you very much. Stephen from Gardena.
Good morning. I hope you guys can hear me. I'm actually in the car. I'm driving, not at work today. But for us, it's gotten very busy. For us, we have a small ER. We only have a 10-bed ER. We're seeing anywhere from 105 to 130 visits a day. So we're slammed in there. We've got I think we have 14 COVIDs today, 4 of which are in ICU, 2 of which are on. A lot of our HEPA filters again to create more space on the med-surg floor. We'll be meeting tomorrow with our emergency management subcommittee meeting, and we'll be discussing what we're going to do now as we are starting to see more patients, obviously, in the hospital that are coming in with COVID, with the variant. So we'll be discussing that tomorrow to see kind of what we're going to do with visiting and various other things. Also, the acuity level of the patients coming into the hospital, a lot, and I do mean a lot of mentally ill patients. Obviously, they have health issues because we're not a psych facility, but we have to see them first before we can move them on. And it's finding it very difficult to relocate them. I've had to hire 5 extra security per shift, 7 days a week, to act as sitters for these patients. It's getting pretty rough. So got a lot going on. Very, very busy. That's all I have.
Okay, thank you, Stephen. Catherine Meyer from Kaiser.
Hi, everyone. Good morning. As similar to all the other facilities, we are pretty busy as well here at South Bay Kaiser. Currently, we have 30 COVID positive patients. 4 of them are in ICU. We have a total of 158 admitted. We are at 120% capacity. Our COVID command center has been reactivated. However, it is virtual. And we are also struggling with low staff. So we're pretty much the same boat as everyone else. So I guess we're just gonna try and ride the tide like everyone else. That's all I can give you guys right now. Thank you.
Okay, thank you. And is Cheryl Garzonon from Kindred South Bay? Or Susel or anyone from Del Amo? All right, Jeff, are you still on from Area G?
Yes, good morning. I hope everybody's doing okay in this current situation. Yeah, in Area G, the cities are looking at positive steps to try to limit their COVID infections. I sent out a survey, or the survey was sent out to find out what policies are in place for the cities and agencies. And I know that Essence, you sent yours. Thank you. But we still continue with our weekly calls about COVID with all the hospitals and in the area and all the cities and school districts. And I think that's going to continue for quite a while now with what I see in the numbers. Our numbers are the highest we've had here now since February of this past year. And now I'm gearing up now for training for the Super Bowl because, you know, in February, Inglewood's hosting the Super Bowl, and plus all the affiliate events that are going on everywhere. So I'm starting to do training with the city of Inglewood and all the other cities that are in emergency operations. Our operations group, working with the NFL and the FBI, are starting to get things really ramping up here. So it's going to be a busy time this fall. So that's all I have for now. Thank you.
Okay, and I guess Jeffrey's going to be busy now that he's there. Jeffrey's not the on this city of Torrance, but now moved to the city of Eagle. So, any update on the new Torrance representative?
Yeah, they're working. I think eventually to go out and find out who. But Chief DeMay, Dave DeMay, is right now is the acting person and to be contact. So.
I'll follow.
All right. If you need his email, I'll send it to you.
Okay, thank you. Roy from Heritage.
Yes, hi, good morning, everyone. So we at Heritage are doing, we're doing okay at this time. We are basically 100% vaccinated, all staff and residents. We just have maybe a few, there's about 3 staff who have, medical issues that prevent them to be vaccinated, but everybody else is. So we're grateful for that. We actually mandated it in our facility. So we were able to do that. Just scared about this new variant, I guess. We've heard of other facilities that have outbreaks, and majority of the residents who are positive are vaccinated. So it's just kind of scary for us. And then also, we have a lot of visitation. A lot of our complaints actually right now is because of visitation, because a lot of course, understandable, they want to come and visit. And we're trying to limit it to certain times and certain rooms and certain areas, and that's where we get the biggest complaints, that they don't have unfettered access to the loved ones. But we do try to just explain that we're just trying to be as safe as possible with everything that's going on. They do understand after a while, but it's just it's just they're it's just they're always something about it. So fortunately right now we don't have any cases, and so we continue to be as mindful of all the infection control procedures that we have, and hopefully we'll see what happens. It's very hard, and it's very scary to think of what's going on out in the community with this new variant. So, hopefully, something happens, or maybe hopefully guidance from the county or the state, and how we can be, we can be better at, against it. So, thank you.
Okay, thank you. And where are you getting the information that most of the newly infected are vaccinated? Because I'm getting the opposite of that from the CDC and public health. We just want to make sure that we're getting it from the, credible sources.
No, that was just one. There was one facility that we know of that had more vaccinated residents who were positive than unvaccinated. So it was just the one facility, which was kind of scary for us.
Okay,
to
could
think
be
about.
demographic.
But for the most part, I know that most of the cases are unvaccinated. The thing is, a lot of the cases that go to the hospital, the vaccinated, I would think that the vaccinated are less severe. So they don't think of going to the hospital. They just do their own quarantine. So it's mostly unvaccinated that's showing up in the hospitals. Kind of is maybe what I'm thinking that's happening.
Okay, yeah, it could be the demographic that you're dealing with is a little unique to what's happening out in the
Right.
community. But yeah, that is concerning.
Yes.
Okay, thank you, Roy.
Thank you. And the vaccinated residents in that facility, they're basically mostly asymptomatic or very little symptoms. So they were positive. So that's the thing. That's the concern.
But their illness is not as severe.
Correct. Yes.
Okay, thank you. And then any other long-term care facilities? I believe I saw Teresa.
We have Lomita Post-Acute Care Center here as well.
But Wayne?
Yes.
Yes. Okay, go ahead.
For Lomita Post-Acute Care Center, we have about, we fluctuate between a 90 and 100% vaccination rate. So right now we're currently at 90% for healthcare workers and residents. We don't have any current cases of COVID at the moment. We are utilizing a source control for our scheduled visitations. That's going pretty well for us. We have about an average of 7 to about 10 visitations per day. At the moment, we are running on 70% capacity in terms of census, and we have a fully stocked closet full of PPE. We do have red zones that are ready. What we're doing is we're just trying to staff up, since we do have to have separate staff for that red zone. Is staffing has been a little bit of a challenge, but we are bringing in quite a bit of people to interview and orient with us, which is really good for us. Other than that, that's pretty much the full update going on at Lomita Post-Acute Care Center.
Okay, thank you. And if you haven't done so already, please enter your information into the chat with your name and the agency you're representing. That way we can easily record it in minutes and don't have to spend 30 minutes doing a roll call. Any other long-term care facilities?
Chris here with Sunnyside.
Thank you, Chris.
Hi. So similar to everybody else, we are doing scheduled visitation. Some families, as Heritage reported, are less than happy, but when we explain, they seem to understand better. We did have a couple of staff who have tested positive off and on over the last couple of weeks, fully vaccinated, no symptoms, done their isolation. And then we are working with public health on all of that in regards to staff and residents. So that's where we're at.
Okay, thank you, Sunnyside. Any other long-term care? All right, we'll move on to clinics. Jennifer, are you still on?
Hi, yeah, I'm still on Essence. Hello, everyone. Good morning. So at this point in time, we are, doing a little refresher. We plan on doing a refresher this week for staff about, just reinforcing masking and social distancing and proper use of PPE and COVID in general. We never quit masking for all staff. We're still required to mask regardless of vaccination status. Previously, we're still, doing our entry screening and that kind of thing. We just reopened our testing clinic a couple of weeks ago. There hadn't been much demand, so really it very much tapered off. So we were not offering a testing clinic previously, and we reopened it a couple of weeks ago. So far, we've only had a few people back, and no one has tested positive. So we're we're doing okay for the moment. And PPE, we've got a fair amount of inventory, and we haven't experienced any shortages yet. Thank you.
Okay, thank you. Carolyn, are you still on? Carolyn Kinahan?
Yes, I'm here. Good morning. Yeah, our caseload is actually higher than it was, surgery cases are higher than it was pre-COVID. We have about 90% of our staff vaccinated. We've had 2 unvaccinated staff that came down with COVID and have recovered. We still have all of our COVID restrictions in place. All patients and staff are screened daily with a COVID questionnaire and temperature checks. All staff and patients have masks. We give masks to our patients when they come in here to replace the ones they're wearing. We are only allowing patients in the lobby unless it's an issue with a minor or a power of attorney or a translation issue. Other than that, limited strictly to patients in our lobby. We do COVID testing on all our general anesthesia cases. And we do follow-ups with our patients, all our surgery cases, just to find out if we've had any patients that have come down with COVID after surgery. So far, we have not had any of that, so we're very happy with that. But we just continuing on with our restrictions. We've never really let them down from, when we had them before. So we're just kind of continuing on with status quo for right now.
All right, thank you, Carolyn. Chris Walter from Harbor Community Health Center. Chris Walter, if you're still on. Okay, Osahan from MOK Ambulatory Care Center. Or Teresa Busi from Pacific Coast Surgical Center. Okay, so there's been a lot of information in the chat, so I'm going to go ahead and provide that to you in an email, all of the links that Keith Gertzweiler sent from Public Health, so that you guys can all have that, as well as his information if you need to contact him for any additional details about his presentation. I'll also send you guys the slideshows. So hospitals, we will reconvene our polls. So just start looking out for that. And we may do like a Zoom meeting, depending. So next week is the check-in on, or I forgot what they call it. I think a post check with the EMS agency on the 5th. And so we'll, see where they go with that. If we end up going to every week, then we'll pick a day that's not on that same day. Is there anything anyone else would like to share? I know today was a long meeting. Sometimes it's like that when we have presenters.
So Essence, this is Chris.
Yes.
So is there, I know that next week's our post check, but we haven't seen any need. Are you guys able to get your supplies, your PPE?
We're currently okay with our PPE. We just got our resupply of the IOC Dover conversion kits that, we used up during the COVID surge. So we're currently like what we call green. Does any other agency have any issues with PPE supplies?
This is Steve with Memorial. No, we don't have any issues at all. I actually ordered early a lot of the extra supplies with the filters and extra battery packs. So we're actually very good. We're in a good situation right now with all of our PPE.
Okay.
And go ahead.
Because currently we haven't seen anything on ReadyNet. We still want to advocate that you go ahead and follow the process, reach out to your vendors first, and then alternative vendors, your sister facilities, and then reach out to us. We haven't seen anything currently. We do have testing supplies if you need those testing supplies, and I know Binex now has been an issue. Some facilities aren't able to purchase them from the manufacturer, so we will escalate those, and the state has been providing those testing equipment and supplies. They have an abundance of it. So if you have any issues with testing or you need that, if we don't have it in our warehouse, we're just escalating it right away up to the state so that we can facilitate that process. Otherwise, just continue with the normal process pre-COVID, which is, you know, your sister facility, your vendors, alternative vendors, and then reach out to us, and then we'll go from there. But at this time, it seems like everyone's doing okay, and that's what the purpose of next week's meeting, to really determine if we need to stand up those weekly calls or bi-weekly or monthly calls, whatever it is. But I think part of it is some facilities at other DRC regions have been calling for us to have the meetings, but I don't have anything new to tell you that you're not receiving from public health. And I think I hope we've done a good job, and I think we have, in preparing people to learn to fish and not to be, you know, always expect us to feed you with that fish. So I think you guys have done an amazing job, and you will continue to do an amazing job. I think part of it is some people would want that reassurance. And are we doing the right things? Are we trending correctly? Should we start standing things up or not? And we really leave it up to your facility. And it sounds like, based on the report out, that you guys are now looking at your numbers. If you need to stand up a virtual command center, great. If not, you're just keeping an eye on it, and you guys will adjust based on the need of your facility.
Okay, thanks, Chris. And perhaps by the time of that meeting, things will change because they are increasing, you know, exponentially.
Correct.
Each week.
So that's why we put it out so far, because if we would have had a meeting this week or last week, it wouldn't have the same type of effect.
Right.
And we kind of put it out 2 weeks, and really a month out from 4th of July, where I think because of the festivities, there's a lot of there wasn't as much restraint.
Okay. Yes, and I totally agree. So we'll see where we are, you know, next week. So, you know, everyone stay masked up, promote the vaccine. It's working. You know, we are seeing the numbers coming into the hospitals of the unvaccinated. So, you know, that's the trend. So good luck. And until we meet again. So just look for those follow-up emails. Oh, and if you have not done so, please put your name and facility in the chat. I'm going to keep it open for a little bit as I save everything and stuff. So if you've already done so, then thank you. I'll give you your time back. This was a long meeting, but you know, we do block out from 9 to 11. So we haven't been going all the way to 11 now that we've been doing virtually, but you know, I think that this was some good information that we had to present today. So thank you, Keith, for joining us as well.
Thank you, Essence.
Thank you.
Thank you.
Thanks.
Thank you, Essence.
No problem.
Amazing.
Thank you.
Thanks, Essence.
Thank you.
Day number 6, couldn't sleep last night. Sometimes I get too pumped on takeoff twos. I know the feeling. Released 2 ounces, shocked as hell. Went too hard for birthday weekend per usual. I work my ass off daily. I don't recommend that for everyone. It works for me. Back on RPP regimen on Monday, like that weekend never happened. I say this to say no matter what, if we go left, we can always come back. We got this. That's right. Listen to her. If y'all didn't get to see Candace's video I posted on the page, just search her name. Check her out, Candace. I love that video. Next up, Dr. Dr. Kiana Caldwell didn't weigh in last week. Got a 7 and down